Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 151 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, JBF, a 45-year-old female patient whose height is 62 inches, and weight is 50 kilograms, was admitted to the intensive care unit for pyelonephritis. She has no known drug of food allergies. Within the first 8 hours, she received 10 liters of bolus crystalloids and was also initiated on a norepinephrine drip to maintain a mean arterial pressure of 65 mm of mercury. Her pertinent lab values include a serum creatinine of 1.8 mg per deciliter. At baseline, her serum creatinine was 1.1 mg per deciliter. So my question to you is, which of the statements listed below best describes initial dosing of antimicrobials in JBF from a PK/PD standpoint? Is it A. Nephrotoxic antimicrobials should be avoided because of potential worsening of kidney injury and reduced clearance of other agents, or B. Initial acute kidney injury on presentation, most often in septic shock, leads to acute tubular necrosis, necessitating conservative antimicrobial dosing on the front end, or C. Loading doses of antimicrobials should be avoided in JBF because of her acute kidney injury, or is it D. Large volume resuscitations are most likely to affect hydrophilic antimicrobials compared with lipophilic antimicrobials? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Large volume resuscitations are most likely to affect hydrophilic antimicrobials compared with lipophilic antimicrobials. This clinical scenario is quite common in the treatment of patients with sepsis, especially those in septic shock. Dosing of antimicrobials from a PK/PD standpoint can be very challenging in these scenarios because of the many patient-specific factors being modified, especially in the first 24 hours. Large volume resuscitations are most likely to affect hydrophilic antimicrobials because these volumes often mimic or are greater than total blood volume concentrations. An example of this would be aminoglycosides that are primarily hydrophilic and that would therefore require an adjusted increased dose in these scenarios, depending on the amount of crystalloid resuscitation. That makes answer D correct. Answer C is incorrect because the benefit of attaining rapid therapeutic concentrations of antimicrobials outweighs the potential increased risk of some antimicrobials, e.g., vancomycin, for further nephrotoxicity. Answer B is incorrect because most cases of acute kidney injury do not result in acute tubular necrosis but rather reverse upon volume resuscitation. Dosing should be more aggressive on the front end. In the era of significant antimicrobial resistance, we often must use more nephrotoxic agents to ensure one agent will be active, e.g., aminoglycosides or polymyxins. In this case, that might not be necessary, but we are not concerned about its affecting the clearance of other agents because we can adjust the doses, frequencies of these agents, which makes answer A incorrect. Let's move to the next question, please. And the next question reads, your clinical team initially treats JBF using IV piperacillin, tazobactam and vancomycin therapy, with both urine and blood cultures 2 aerobic, 2 anaerobic, showing pan-susceptible Escherichia coli. On day 3, JBF therapy is de-escalated to ceftriaxone monotherapy. She clinically improves and is transitioned to the general medicine ward on day 5. On day 7, JBF is ready for discharge. The team inquires about the potential for transitioning the patient to oral therapy. So my question to you is, which agent has optimal absorption for potential use in JBF's case in this planned IV to oral switch? Is it A. nitrofurantoin, or B. co-amoxiclav, or C. cefdinia, or is it D. levofloxacin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. levofloxacin. Fluoroquinolones have excellent absorption, making them the go-to oral de-escalation agents for many patients requiring discharge from the hospital for diseases such as community-acquired pneumonia or pyelonephritis. That makes answer D correct. Oral beta-lactams have moderate absorption in most cases at best and thus are not the best agents for discharge in patients who have been hospitalized for infection with bacteremia, which makes answers B and C incorrect. Nitrofurantoin should not be used in systemic infections because of its lack of concentration outside the bladder. That makes answer A incorrect. Please advance to the next slide. And the next question reads, KVS, a 67-year-old male patient presents to your accident and emergency department with a past medical history significant for HIV, hyperlipidemia, osteoarthritis, type 2 diabetes mellitus and hypertension. He has a chief complaint of an upper GI bleed. Currently he takes metformin, atorvastatin, ibuprofen, emtricitabine tenofovir, atazanavir boosted with ritonavir, and lisinopril co-formulated with hydrochlorothiazide. After stabilization with 72 hours of intravenous pantoprazole and cauterization of his bleeding vessel, he is initiated on 40 mg of oral omeprazole twice daily, together with his home medications. Ibuprofen is discontinued, so my question to you is, which drug-drug interaction is most likely with the addition of his omeprazole therapy in KVS's regimen? Is it A. decreased absorption of atazanavir, or B. decreased absorption of emtricitabine, or C. decreased clearance of metformin, or is it D. decreased conversion of atorvastatin to its active metabolite? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Decreased absorption of atazanavir. Several significant drug interactions are important for the clinical infectious diseases pharmacist, many of which will not necessarily be caught by the general specialist. Atazanavir, a protease inhibitor used in the treatment of HIV, requires an acidic environment for absorption, therefore, restrictions on acid-suppressing medications exist. For treatment-naive patients, omeprazole equivalent dosages of 20 mg or less cannot be exceeded. For treatment-experienced patients, proton pump inhibitors are not recommended. That makes answer A correct. Atorvastatin is primarily a CYP3A4 substrate and will not be affected by omeprazole, which makes answer D incorrect. Omeprazole is primarily hepatically metabolized and will not affect metformin clearance. That makes answer C incorrect. Emtricitabine is not clinically affected by omeprazole co-administration. That makes answer B incorrect. Please advance to the next question. And the next question reads, GCB, a 77-year-old male patient residing in a nursing home is transferred to your hospital with complaints of abdominal pain, nausea, vomiting, fever, and hypotension requiring aggressive volume resuscitation and vasopressors. She has a past medical history significant for several hospital admissions with significant antibiotic exposure. He suffers from chronic kidney disease. He had a baseline serum creatinine of 3.1 mg per liter. Currently his serum creatinine is 3.4 mg per liter. He is hypertensive and suffers from type 2 diabetes mellitus and hyperlipidemia. A diagnosis of perforated large bowel is made, with surgical options being discussed. The team wishes to use tigecycline therapy for his secondary peritonitis. So my question to you is, which of the statements listed below best explains why tigecycline might not be an ideal therapeutic option for GCB's case? Is it A. Tigecycline's serum concentrations may be insufficient when treating patients with septic shock, or B. Tigecycline may worsen GCB's risk of acute on chronic kidney injury. C. Tigecycline's VD is low, limiting penetration into the intra-abdominal space. D. Tigecycline does not contain appropriate antimicrobial coverage for this infection. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Tigecycline's serum concentrations may be insufficient when treating patients with septic shock. Tigecycline is a glazocycline antimicrobial that has a very high volume of distribution, which makes it useful for several infectious diseases, including intra-abdominal infections. However, because of this large VD, its serum concentrations are lower than required to treat patients with bacteremia. Therefore, tigecycline should be avoided in patients with septic shock, especially when source control is problematic. That makes answer A correct and answer C incorrect. Tigecycline contains appropriate coverage for most organisms commensurate with intra-abdominal infections, which makes answer D incorrect. Tigecycline undergoes primarily hepatobiliary excretion and thus would not worsen this patient's acute kidney injury. That makes answer B incorrect. Please advance to the next question. And the next question reads, CMM, a 65-year-old female patient presents to your accident and emergency department with the following signs and symptoms: fever, chills, dysuria, and flank pain. She is admitted to the general medical ward for treatment and initially placed on piperacillin, tazobactam. She has a past medical history significant for recurrent Clostridioides difficile infection. She completed her last treatment 2 weeks ago. Her urine culture grows Pseudomonas aeruginosa that is susceptible to cefepime, meropenem, piperacillin, tazobactam, and tobramycin. The team wishes to switch to tobramycin to use the narrowest therapy because of her recent history of Clostridioides difficile infection. CMM is initiated on high-dose, extended interval therapy at 7 mg per kilogram daily. So my question to you is, which of the statements listed below best describes using this method of aminoglycoside dosing? Is it A. Serum monitoring is not required with extended interval dosing, or B. Extended interval dosing is preferred in enterococcal endocarditis, or C. Nephrotoxicity is equivalent to or less than traditional dosing, or is it D. Extended interval dosing is best described in pregnant females? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Nephrotoxicity is equivalent to or less than traditional dosing. Aminoglycosides are dosed using primarily two methods in clinical practice, namely 1. Traditional dosing and 2. High-dose extended interval dosing. Although extended interval dosing better maximizes the PD of aminoglycosides, clinical outcomes data are lacking to show its superiority to traditional dosing. However, nephrotoxicity is equivalent to or less because of decreased saturable uptake in the nephron using extended interval dosing. That makes answer C correct. Extended interval dosing has not been well studied in pregnancy. That makes answer D incorrect. Although extended interval dosing is appropriate in treating some causes of infective endocarditis, caused by Streptococcus species, traditional dosing is recommended when treating enterococcal endocarditis. That makes answer B incorrect. Although peaks or troughs are not monitored in extended interval dosing, random concentrations on the basis of nomogram are still sampled and monitored. That makes answer incorrect. Please advance to the next slide. And the next question reads, ALJ, a 55-year-old male patient is being treated for Enterococcus faecalis with ampicillin and gentamicin. He has a past medical history significant for poorly controlled hypertension, type 2 diabetes mellitus, and end-stage renal disease. So my question to you is, which of the statements listed below best depicts the most appropriate time to sample ALJ's gentamicin concentration? Is it A. A specific sampling time is not required for aminoglycosides in hemodialysis because of end-stage renal disease, or B. Wait a few hours to obtain the concentration because it will decrease significantly within the first few hours post-dialysis, or C. Wait a few hours to obtain the concentration because the concentration will increase significantly within the first few hours post-dialysis, or is it D. Obtain the concentration just after hemodialysis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Wait a few hours to obtain the concentration because the concentration will increase significantly within the first few hours post-dialysis. Redistribution occurs with many medications, including aminoglycosides, after cessation of a hemodialysis session. Therefore, their concentrations will increase significantly a few hours after the session has ended. That makes answer C correct, and answers D and B incorrect. Even though the patient is in end-stage renal disease, aminoglycosides should still be sampled at the appropriate time, which makes answer A incorrect. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 152.